medical oncologists at Sunnybrook who are an integral part of what we've been doing. I'll start off by giving some background, and then I'll move on quite rapidly to what I think are the most recent and exciting results that we have. So the clinical problem that we're investigating is one of how to enhance the effects of chemotherapy. And that's not necessarily just limited to primary disease, but also potentially useful for metastatic disease. And so if you look at all chemotherapy for breast cancer, it works. It works well, but not in all cases. And complete response rates for tumors can be anywhere from 10 to 20%, with partial response rates higher. And there are still patients which actually do not respond. So the approach that we've developed here is potentially applicable to anyone with a partial response or no response to chemotherapy. And so the driving discovery behind this was one made by me and actually the new Vice President of Research at SRI, Michael Kolios, who's joining Sunnybrook in May. A number of years ago, he and I discovered that you could actually detect cell death with ultrasound. And that was done using rather what is by today's standards considered rudimentary ultrasound equipment. And this is an example of that first experiment that we did, where this case we took acute myeloid leukemia cells and exposed them to cisplatin chemotherapy for 0, 6, 12, 24, and 48 hours. And it was observed that there were significant changes in backscatter intensity of the ultrasound at 12 or even 24 hours, with some changes even at 6. And so we didn't quite understand what was going on. And a great deal of work was expended both characterizing the ultrasound signal changes, and you can see some of those here. There are changes when you use an ultrasound transducer, if you like, as a spectrometer in the slopes and midband fits and 0 megahertz intercepts of these lines. And I'll explain what these mean a little later. But we were able to link that to the development of cell death and the condensation and cellular structural changes that go on. So 20 years later, this technology has now been used at Sunnybrook and in other sites for clinical trials that we've been running, along with the surgeons and the medical oncologists and the radiologists. For diagnostic purposes, we've enrolled over 400 women. For chemotherapy monitoring and more recent work in prediction, again, over 400 to 500 women. We've compared a number of different ultrasound instruments, done multi-site validations, and extended the technology to head and neck and prostate tumor. And even now, this number is now doubled to 150. We've actually, with the lead of medical oncology, conducted randomized controlled trials using this technology to allow the medical oncologist to personalize and customize chemotherapy. So I'll just show you some of the early results where we scanned patients with ultrasound methodology before at week 1, week 4, week 8 of their chemotherapy. And for the most part, patients receiving neoadjuvant chemotherapy for gross tumor in place continue to be scanned this way on these various different trials. As you can see, some of these patients have large, bulky disease to begin with, and for which they're receiving neoadjuvant chemotherapy. And we were able to show that in patients who are non-responders, so these are quantitative ultrasound images before, then at week 1, week 4, and week 8 of chemotherapy. You can see some patients do not change, whereas other patients begin to exhibit changes in the quantitative ultrasound images at around 4 weeks of chemotherapy. And this increased backscatter that I'm showing here is one particular feature type that is associated with cell death. And we were able to demonstrate that that correlated quite well. This is a patient who was a responder, and you can see there's very little tumor left, maybe some tumor bed here with low cellularity. Whereas in patients that were non-responders, there were large, bulky tumors left in place. So we were able early on with some of those rudimentary ultrasound measurements to be able to correlate their ultrasound changes with clinical outcomes. We had an early inkling that we could separate non-responders from responders with some of these image features, and then set forward to optimize all of this. It turns out that these different types of parameters actually have real life meaning. So even in our first work in 2005 to 2007, we were able to identify that from whole mount histopathology that patients who were responders actually did quite well in terms of their survival, and non-responders clinically did not survive. And if you actually predicted whether someone was a responder or not using the quantitative ultrasound, you could find once you began to use more sophisticated measures. So this was a first generation classifier, but a more sophisticated second generation classifier actually mimicked what went on with their real life responses to chemotherapy. So we were able to very early on, at 4 weeks of chemotherapy, predict whether someone was going to be a survivor or actually not. And the survival curves paralleled what happened with the real life survival curves. We then began in about 2012 to 2013 to begin to involve texture-based approaches. So it became obvious from these studies that we were doing that not all tumors responded uniformly, but rather there were areas in the tumors, such as that shown here. So this is a responding patient. This is one ultrasound feature here, another one here, another one here. The tumors are color-coded by these ultrasound features. The scale bar here indicates 1 centimeter. And you can see here as early as 1 week of chemotherapy, you can begin to see areas that are responding. And certainly by 4 weeks, you have a good idea that some of these ultrasound parameters are changing in patients that were deemed to be clinical responders according to RECIST criteria. In contrast, the non-responders, you can see that the images remain mostly the same and are unchanged. How do these texture analyses work? Well, they're the same sort of approaches that you can use on your cell phone to make yourself look younger or more beautiful, if that's what you're interested in. They compare each pixel in an image to its neighboring pixel, and then one can begin to calculate things such as entropy or busyness or homogeneity. We learned early on that some of these parameters were not particularly useful. They could not be used to differentiate responders in the solid squares from the non-responders in the open circles, whereas other parameters as early as week 4 and some even as early as week 1 could actually do that. So we spent a great deal of time early on developing classifiers with groups of 100 to 200 to 300 patients, and using what are now considered standard machine learning based approaches to actually develop AI-based or computer-based algorithms for separating patients into potential responders or non-responders, and monitoring and predicting whether that's what they were going to be. And it turns out that if you introduce texture methodologies, again, you can mimic what goes on in terms of histopathology. So again, these are outcomes here for these patients obtained at the time of mastectomy after their chemotherapy is completed, and we actually followed patients for disease-free survival. You can see here, again, responding patients do quite well, whereas non-responding patients eventually succumb to their disease. And we were able to, using these methods as early as week 1 after the start of chemotherapy, make predictions as to whether patients were going to survive or not, disease-free, that mimicked what actually went on with their histopathology. Turns out that week 1 is a bit early to do so. The data at week 4 are probably more robust. We then began to expand this work involving molecular features as well, and doing other things, such as beginning to separate complete responders from partial responders from non-responders. And there, it turns out that you can develop image features which are slightly different, which can predict the 3 different classes here. Again, in terms of what goes on in reality, in terms of clinical pathology, with complete responders here in blue, partial responders in red, and non-responders in green, we can begin to obtain similar survival curves after 4 weeks of chemotherapy in terms of making predictions, and begin to classify patients either as complete responders or partial responders early on into their many months of chemotherapy. The next generation of work was based on the realization that there's actually information in these tumor images before patients even start chemotherapy. And so we were able to develop classifiers before the start of chemotherapy that it can actually be used for predictive purposes. So not looking at tumor cell death, but inherent tumor structure before chemotherapy starts. And so this is a simplified method-based slide. What you're looking at here in this panel is normal breast tissue, then grade 1 tumor, grade 2 tumor, grade 3 tumor. These are examples of what some of these ultrasound parameters look like. This one is the scatterer spacing, so the space between ultrasound scatterers. This one here is the estimated scatterer diameter. That's how big the ultrasound scatterers are. And this one here is the estimated scatterer concentration. So that's the concentration of ultrasound scatterers. And you can see here, even between normal tissue, grade 1, grade 2, and grade 3 tumor, if you read each of these out as a vertical strip, this, if you like, acoustic fingerprint of this tumor here, a grade 2 tumor is very different than the acoustic fingerprint of a grade 3 tumor. And it turns out that that same sort of information can be obtained beforehand and correlated to tumor response. And so we were able to carry out work looking at the inside of a tumor and the tumor rim, and making ultrasound characterization measurements of those regions, and then applying the same sort of texture analyses that I showed you to begin to predict patients that would have a good response or a poor response to chemotherapy using this information. And it's very difficult to do so just by visual inspection. So again, we had to use similar machine learning approaches, and we're able to obtain accuracies of close to 90% in terms of predicting whether a patient would respond to their chemotherapy or not before the chemotherapy was actually given. And again, this is actually now slightly higher. We're operating at a sensitivity and a specificity and the accuracy of about 90 to 92%. And again, these predictions mimic pathology. So again, in a cohort of patients, again, the responders do well, the non-responders do not. And if you actually look at predicting survival based on whether they were predicted to be responders or not before the start of chemotherapy is actually given, making that prediction on the basis of the ultrasound data before the start of chemotherapy, you can develop tools that actually mimic real-life survival curves. So we've continued to refine the methodologies, exploring, for instance, artificial neural networks, and using these again to determine from responders and non-responders which parameters were useful and which ones were not. And there we were able to actually obtain performance accuracies of close to 96% in terms of predicting whether patients were going to respond or not. We explored a number of different analytic models and have developed different ways of dealing with this data and have modernized it over the last 2 decades as more and more methods came out. So you actually don't need necessarily specialized ultrasound equipment to do so. We've actually compared different manufacturers and implemented these methods on a number of different platforms. We've validated the methodology through multi-center studies, the largest being patients at Sunnybrook, Princess Margaret Hospital, St. Michael's Hospital, and MD Anderson Cancer Center, with centralized data analysis showing it doesn't have to be done at Sunnybrook. The methods are relatively easy to implement so long as you have standardized good ultrasound data. We've actually begun to do more sophisticated things, not just one pass of texture analysis, but 2 passes of texture analysis. That's color coding the images based on their texture and then looking for repeating patterns. And a lot of these images begin to look somewhat slightly psychedelic as you begin to look for repeating patterns. And each of these approaches tends to add on anywhere from 4 to 5% increases in accuracy in terms of characterizing tumor responses. And again, we're operating at over 90 to 95% accuracies in terms of predicting responses. The more recent work that we've done, and I'm not going to show I'm not going to show it here, has actually started to explore deep learning approaches, and that's with Ali Sadeghi at York University in Toronto and Michael Kolios's team at Toronto Metropolitan University. And again, we're mimicking what goes on in the patients in terms of their tumor response and their survival. The more recent work that I want to spend some time on the next 10 to 15 minutes is actually an interventional clinical trial that's been run by Medical Oncology using this technology to personalize chemotherapy. We first published a preliminary analysis with 60 patients. We've now published an interim analysis with 120 patients and are on our way to recruiting to a target of 240 patients, where what's been done in this study is that the patients have been randomized to just collecting the ultrasound data alone and monitoring their responses and not providing that information to the treating medical oncologist, to the interventional group where that information is actually provided to the treating medical oncologist, and they can use it at their discretion to continue chemotherapy if the patient is a responder, or if the patient is a predicted non-responder, to be more vigilant, or to actually, in certain cases, oncologists have actually changed treatments. So this study involved 146 patients that were randomized to the 2 groups that I discussed. This is what some of that data actually looks like. This is a responding patient at week 0 before the start of therapy, week 4. These are non-responding patients at week 0 and week 4. These are the plain vanilla ultrasound images up top. The scale bar here is 2 centimeters. And you can see here at week 4, this parameter is different than this one, indicative of tumor response. This one here has changed compared to this one. And again, in the non-responders, the tumors and their quantitative ultrasound data are relatively invariant. This is a feature analysis plot. So in this study, we generate a class score. That score predicts whether a patient is going to be a responder or a non-responder. You end up with a value that tells you how sure you are. So the further you are away from this middle area, the more certain are the results. Some patients are misclassified because, again, we have an accuracy of order to 90 to 95%. And here we actually color-coded patients by either being complete responders or some being weak responders, in which there was a large tumor bed left behind, although the cellularity in that tumor bed was relatively low. This is a Sankey diagram of what happened to these patients. So in the observational arm, patients continued their standard of care chemotherapy. You can see that P is predicted, A is actual. So there were some patients here that were predicted to be non-responders, but ended up weak responders, probably because the second phase of their chemotherapy worked better than their first phase, or they were slow responders. Whereas in this case here, in the experimental arm, patients ended up being non-adapted, meaning that the medical oncologist decided to not make a treatment decision modification, and there was a small group here of patients that were predicted to be non-responders, and then their chemotherapies were changed and they were converted to be responders. Right? This patient here was predicted to be a non-responder and then ended up not being adapted and actually ended up going through and ended up being a non-responder. And that's the hope, is that you can convert these types of patients. Obviously, patients respond to their second phase of chemotherapy if the first phase doesn't necessarily work in ones that are non-adapted, but the goal here is that in the future, they could be potentially switched to that second phase of chemotherapy much sooner, or in cases where they end up being weak responders, may benefit from further therapy. So in terms of the patients that were adapted, one here had their AC treatment stopped early and went on to the second phase of their chemotherapy, to which they responded. And that's likely the most common scenario. This patient here didn't respond to their second phase and then went on to have early surgery. This patient here had 3 cycles of AC and then was switched to intensified paclitaxel treatment. And this patient here went on to have early surgery and then received adjuvant chemotherapy afterwards. So do these ultrasound measures actually carry information that's more significant than size change? The answer to that is yes. If you look at size changes at 4 weeks into the start of chemotherapy, it turns out that although they are size changes, they're not statistically significant, whereas the class scores for these patients who are responders, so that's this group here, actually are statistically significant. And so you can begin to predict very early on whether someone's going to continue responding or not, whereas tumor size doesn't necessarily carry that information. This is just some examples of what these patients actually look like. These are responders, and what their ultrasound images actually look like. These are, again, more responders. These are non-responders shown here. We'll just skip this slide in the interest of time, but again, the accuracy of the work is over 90 to 95%. Again, here, this is a little easier to look at. This is just looking at responders, non-responders, and the patients who are actually switched. So one could argue that these patients that were predicted to be non-responders that ended up non-responders could potentially benefit or could have benefited from a change in their chemotherapy and could have been brought over to this group, which is what happened to these blue patients here, where the medical oncologist used this information to change chemotherapy. If you look at the data after mastectomy, then of course the complete responders have no tumor left behind. The tumor completely resolves, and there's a correlation between the class score and what happened long-term after mastectomy to these patients. So I'm going to summarize here. We've been able to develop classifiers that not only predict, but also monitor chemotherapy. The technology is now in clinical evaluation as we continue this phase 2 trial, and I'm going to be reminding the medical oncologist to keep considering changes in chemotherapy with this extra information. We're actually now implementing this methodology on handheld ultrasound scanners. So you won't need a radiologist in the future potentially to make these measurements, but you could imagine yourself as a medical oncologist with having an ultrasound device that fits into your pocket that can provide you a readout as to whether a tumor is predicted to respond or not. And we're implementing this as well in sort of cart-based and bed-based systems. And we actually now have this kind of tomographic device as well, into which we're going to be implementing this methodology. So I'm going to end by acknowledging all the people that have played an important role. Not everyone is listed here, but David, Martin, Joyce, Maria, and Elwin are the various CRAs and lab personnel that are involved in recruiting and imaging patients. Lakshman, Oscar, Amir, and Murdad, postdoctoral fellows that are developing the various different and research associates who are developing the algorithms. All of the medical oncologists, surgeons, and radiologists are involved in this way in one work or another. Ram Mohabir has been involved in coordinating a great deal of the administrative work necessary for this. And Michael Kolios, who's shown here, is your next Vice President of Research, who's been involved in this work as a physicist and a scientist since day one. So on that note, I'll end and acknowledge the various different granting agencies that have provided important funding over the last 2 decades of this research. I'm happy to take any questions.
Hey, thanks so much, Greg, for that excellent talk and overview. If anyone has questions, please feel free to unmute, or you can put your question in the chat. Maybe I'll start with a question, Greg. It seems quite interesting, those handheld ultrasounds that you showed. Where are those in terms of development? Like, where along the pathway are they already being used in the study, or?
They're being used in the observational studies. They aren't being used in the chemo switch study, the one where we're providing the information, as we're still fine-tuning the algorithms. You have to make subtle changes when you necessarily switch ultrasound platforms, but the results are very comparable. If you're in clinic next week, I'll bring one to clinic and you can actually try it out. It's really to use as a point-of-care ultrasound device to actually look at the patient's tumors if you're interested.
And how does it work, I guess, because you had mentioned the medical oncologist could potentially assess response versus not using this handheld device. So would you, I guess there must be a planned way where you image and then what shows up on the screen? Can you describe that a little bit?
So we've actually generated a real-time analysis, not with a handheld device, but with a conventional ultrasound device that can actually color and code the tumors with some of those features that I've shown and do this analysis almost in real time. So a number of graduate students built a GPU processing device which communicates with the ultrasound scanner in real time and uses GPU cards to actually do those calculations in near real time. So I can demonstrate that as well.
That's exciting. Does anybody else have any questions? I guess maybe Greg, as one of the leaders in the field of focused ultrasound in terms of tumor response, what's the next big, direction in the field that you're hoping to pursue in future trials?
I think in terms of this, the goal is to actually get it to the point where the medical oncologist can actually have a real-time handheld unit and start doing this themselves. I think that's going to be the next push. The equipment has now been miniaturized, And we just now have to optimize things and fine tune the algorithm so they can also run in real time with some of these handheld scanners. And then it's up to the medical oncologists to decide what the best thing to do is in a non-responding patient. So I think this is new information that's been otherwise unavailable that you'll have to figure out how to use it. But certainly from a patient point of view, if you were a patient, I think you would want to know, right, that your chemotherapy is going to work and it is working. And certainly if it wasn't working, I would imagine, well, if I was a patient, I would turn to the medical oncologist and say, what can you do? Now
Right.
they
Yeah.
can.
Especially when the tumor clinically, right, on physical exam isn't responding, and it's really important to think
Yeah.
about other steps. Right. Anybody else have questions?
Yeah, hey, Kasia, it's Rosanna. I have a question. Greg, that was a great presentation. I'm sorry I missed the beginning of it, but I was wondering if there was any kind of thoughts going forward about potentially applying this in the metastatic setting. Like, say, if you have a patient with like liver metastasis where you want to get like kind of an early indication if there's response to their systemic therapy,
You,
maybe before they get that first, CT scan or other imaging.
you probably can. We haven't tried it with ultrasound. The other thing that we've done where it may be potentially useful is we've developed comparable algorithms and approaches using both CT and MR. So it turns out all the diagnostic CTs that you order for metastatic workup, CT scan thorax, the information that's in the CT scan thorax of the breast tumor can also be used for this kind of approach. The algorithms don't have as a high end accuracy. You probably need more patients in order to generate ones of high accuracy, but just the plain CT scan thorax, you can generate algorithms with about an 85% accuracy for predicting
Hmm.
breast tumor response. And certainly, I'm sure you could do so with liver mets. We've not had the time to investigate that.
Mm-hmm. Okay, great.
Great. Any other questions? Last chance. Otherwise, we'll give everybody back 15 minutes to their day.
Okay. Thank you, everyone.
Okay. Thanks, everyone.